So my name is Steve Ytterberg. I'm a rheumatologist at Mayo Clinic in Rochester, Minnesota, and have been there for about 20 years. I've been affiliated with the Myositis Association for I honestly don't recall how long. This is my second stint on the medical advisory board, and I'm the physician representative from the medical advisory board to the board of directors for this year and next year, and I'm pleased to do that. So I get to talk about basics of myositis. So how many are here for the first time? Everybody. Okay, that's good. So this is a pretty big picture overview about myositis. It actually has a lot of the same material that Dr. Mayman talked about at the opening session yesterday. So you can think of it as repetition or you think of it as reinforcement. Hopefully it'll help reinforce, but get some of the same ideas across, but maybe in a different way. I do some consulting work that has nothing to do with myositis, and really nothing of the drugs I'm going to talk about are approved by the FDA other than steroids. So I know usually people here for the first time have a lot of questions, and I like to leave time for questions, but I'm going to preempt some of the questions and ask them myself. So what I'm going to try to talk about today is to answer some of these questions. What is myositis? What causes myositis? What does myositis do to patients? How is it diagnosed and how is it treated? So what is myositis? Simply, myositis means muscle inflammation. Itis, inflammation, myo, muscle. Myositis is muscle inflammation. Answered the first question. So here are some pictures from or images from a paper that Dr. Mayman published a few years ago. And basically, this is a muscle fascicle. And I'll show you in a minute what that is. And each of these little round things in between, or somewhat rounded, are muscle fibers, which are the cells of muscle. So it's to think, in this diagram, here is bone, tendon attaches to the bone, and muscle, when it contracts, pulls on the bone to move the muscle. To move the bone. Pulls on the tendon to move the bone. And so here in the muscle fibers are grouped into fascicles. So it's a bundle of muscle fibers, basically. So the group is called the fascicle. The individual rounded cells are the muscle fibers. So to go back to where we were, here is a fascicle of muscle fibers, and this is basically normal. Here's the fascicle, or here is a fascicle, sort of this triangular group of muscle fibers, and they're all surrounded by these blue dots, and these blue dots are inflammation cells. And it is the inflammation that in this muscle biopsy is inside the fascicle and surrounding individual muscle fibers. And this would be a biopsy from a patient with polymyositis, or it could be a biopsy from somebody with inclusion body myositis. The inflammation there is within the fascicle and surrounding the cells. In dermatomyositis, down here in the lower left, so here is a fascicle over here. Here's another one down here, and pieces of others. The inflammation is outside of the fascicles, and that's where the blood vessels are. So the inflammation is in a different place in dermatomyositis than it is in polymyositis and inclusion body. They both have inflammation. They both are myositis, muscle inflammation, but the inflammation is in different places, and that gives the clue that these are different diseases. So myositis is muscle inflammation. And here are some other images from another website that I borrowed them from. So here are blood vessels. Here's a fascicle. The inflammation is around the blood vessel outside of the fascicles. This would be dermatomyositis. Here's a blood vessel again, dermatomyositis. And here's the polymyositis, or IBM one. So it's inflammation of muscle. The other term that gets used is myopathy. So the pathy part means it's abnormal. So this is abnormal muscle. So myopathy is a general term for muscle abnormality. Myositis is muscle inflammation. And what I'm going to talk about a good bit is the fact that most of these disorders come about because the immune system gets misdirected and attacks the body itself, and we call those autoimmune processes. So in autoimmunity or an autoimmune process, the immune system gets misdirected. So it's usually a good guy fighting off viruses and bacteria trying to get into the body, but can get turned around and attack the body itself, and that's an autoimmune process. So, and that's what I'm saying with the lower bullet point. So myositis and autoimmunity are sort of big concepts. So as Dr. Mayman mentioned yesterday, thinking of these idiopathic inflammatory myopathies, these were originally clearly defined in this sort of landmark article from 1975 by Bohan and Peter. And they defined two separate main types, polymyositis and dermatomyositis, and observed that these can occur in isolated forms in adults. And that gets to the idea that sometimes they can occur with other autoimmune diseases as an overlap disease at the bottom of that bullet list, with other disorders such as lupus, scleroderma, rheumatoid arthritis. So there's isolated adult polymyositis, dermatomyositis. There are juvenile forms of this. In kids who get myositis, it's almost always dermatomyositis. Then there are patients who have myositis associated with malignancy. They identify it as a separate category. And then this overlap group of diseases. Now, since then, things have evolved, and we've recognized inclusion body myositis. Inclusion body myositis has actually been described before their paper, but just barely before. And so now we add inclusion body myositis, anti-synthetase syndrome, which I'll talk about in more detail in a little bit, where there's inflammation in the lung as well as other places, but primarily the lung we worry about with that. And then this newly recognized one, or more recently appreciated over the past decade or so, called immune-mediated necrotizing myopathy. And in it, there's not inflammation, hence the myopathy, not myositis. But it is driven by the immune system. So it's the idea that the immune system mostly causes trouble because of inflammation, but it can cause trouble in tissues by other mechanisms other than inflammation. So to keep it as IIM, I sometimes think of these as idiopathic immune-mediated myopathies so that I can keep that bottom one in. But there's still the idea that these are autoimmune disorders affecting muscle, most of which have inflammation and are myositis. So, first quiz, what is myositis? Good, okay. That's the Myositis 101. There it is. Okay. So what causes myositis? So cause is a difficult term to consider. And just because something is associated doesn't mean it caused things. So I have discussions with patients all the time. Why did I get this? I was well. A week, a month later, I'm sick. I've got this illness. What caused it? There must be some reason. You've got to give me an explanation. Was it the flu shot that I got? Was it the episode of dysentery that I got after eating the bad pie at Thanksgiving? You know, well, there must be some cause. I was well, I was sick, in between something happened. And that's a problem to say that something actually caused disease. So just to make this point that correlation or association does not mean it's causal, I found this on the internet, a graph that correlates in red the number of people who drowned by falling into a swimming pool with the number of films that Nicolas Cage appeared in each year. And those graphs sort of, they match pretty well, but there's no way that the number of films Nicolas Cage made had anything at all to do with the number of drownings, right? So, yeah, I don't know. Maybe the films were, yeah, they were so bad that they just stumbled. Okay. So the other reason that cause is a difficult term is, what's it mean? What does cause mean? So I'm going to talk briefly about two different concepts that I think of cause. One is thinking of a trigger. What is it that triggers the disease? And the other is, what are the mechanisms that lead to the muscle inflammation? Both of them really mean cause to my mind. So on the disease trigger side, people think about genetic factors, environmental factors, and sometimes the idea that maybe just changes in the muscle fiber itself may be a trigger, and that gets to some thinking about inclusion body myositis that we'll get to later. On the mechanism side, I'm going to talk a bit about the immune system, inflammation, muscle damage, and maybe other things as mechanisms. So myositis is likely triggered by genetic and environmental factors. And maybe in different patients, these circles are different sizes, that genetic factors are more important for some patients or some diseases, environmental factors more important for others. But most of us in this field think that there are a couple of things that sort of get to the point where there's inflammation that's pushed by the immune system. So on the genetic side, I'll just show you some technical things. So these are genome-wide association studies. In these types of studies, researchers take DNA from large groups of patients with disease and large groups of people without disease that are matched. And this looks for thousands of genetic variations at individual sites. And across the bottom are representations of individual chromosomes and the individual SNPs, or those variations. This is called a Manhattan plot because of the things shooting up like a skyline. And what goes up really high is in orange or red there, and this is associated, the strongest association is with this MHC, or major histocompatibility complex. These are identified for transplantation, markers that are important for transplantation, and the immune system recognizing foreign things to try to reject. And so the strongest association is with variations within this recognition part, the MHC of the immune system. There are some others that go up, but that's really the strongest. So this is in dermatomyositis and juvenile dermatomyositis compared with control patients or control people. Here is our GWAS studies in polymyositis at the top and dermatomyositis at the bottom, again compared with control healthy people. And so what you see here is that things are different. In the polymyositis patients, this PTPN22 is the most strongly associated, and it doesn't pop up in the dermatomyositis patients. Similarly, what goes up in dermatomyositis, we can look at this, we don't see over here. So there are differences between the polymyositis and dermatomyositis. So this is one of the pieces of information, like I said, with the biopsy specimens where the inflammation is different. Polymyositis is different than dermatomyositis. And finally, this has been done in IBM, and again, what pops up here, you can't read the fine print, it says MHC, so it's that same immune recognition area is the important genetic driver for patients who have, this is sporadic IBM, not hereditary. Then to shift gears to environmental exposures, this was from a nice article looking at a survey of environmental factors perhaps related to autoimmune disease in general, not just myositis, but all sorts of autoimmune disease. And these sort of group the types of exposures that have been linked to a variety of different autoimmune diseases. So these authors put together chemical factors, physical factors, and biologic factors. And I don't know if you recall the case that Dr. Mayman talked about yesterday. The very first patient that he described is the first patient described and published with dermatomyositis. Does anybody recall what the occupation was? Stonemason. And what's at the top of the chemical factors? Silica. And so silica exposure has been linked to a number of autoimmune diseases, stonemasons, I'm not sure what other jobs, but there are a number of things. With myositis, the data are not very good. There's some suggestion for silica exposure. Probably the best data related to myositis is for smoking, and especially in patients who have interstitial lung disease and smoking. But this is still work in progress. The other physical factor that clearly is a trigger for flares and may induce disease is UV radiation, which Dr. Mayman talked about yesterday also. So if you look at how to put it, the ratio of patients with dermatomyositis divided by patients with all myositis, the proportion of dermato goes up the closer to the equator you are. So living in Minnesota, you can say there's probably going to be fewer patients. Of patients I see in my clinic with myositis, maybe I'll see more polymyositis and less dermatomyositis. But again, there are hints, but not great evidence at this point for most of these. So then to switch to the cause thing of what are the immune system mechanisms, I've broken this into dermatopolymyositis and IBM. So this increased class 1 MHC, so again this is this MHC immune recognition signaling pathway. Muscle fibers in all of them have an increased expression. I'll show you this picture in a minute. So this has to do with what's called the innate immune system. So this is sort of the starting point for the body's immune system recognizing foreign things coming into the body. And so it's not specific for influenza or staph or strep, but it just says, gosh, this is something that's foreign, and sort of is the first alarm signal that brings up this interferon that Dr. Mayman talked about yesterday, and the interferon then makes the MHC on muscle go up. After the innate immune system, there are two main parts of the immune system. We think of antibodies that are related to B cell mechanisms, and I'll talk about antibodies later. And then the other part is the cellular part of the immune system, where individual cells seek to kill off virally infected cells. And so there's these two main parts of the B cells and T cells, and there are clear evidence for T cell mechanisms in all, but B cell mechanisms are most strongly shown in the dermatomyositis patients. And finally, we get to inclusions, which are unique, not part of the immune system, but unique in the pathogenesis of IBM. And all of them have now been shown to have some autoantibodies. And again, we'll talk about that in more detail. So this is a muscle biopsy image showing this increased expression of this MHC class 1, the immune recognition substance. So again, these are individual muscle fibers in a biopsy, and here you can barely see them. What's brown are blood vessels, but here there's a lot more brown, and this is staining on the muscle surface, or muscle fiber surface, that makes the muscle fibers a better target for the immune system, basically. I show this in almost all talks I give because I think this is one of the key findings that was ever published about these diseases. So this is from '84, and this shows activated T cells, so that part of the cellular immune system, these T cells, invade and damage muscle in IBM and polymyositis. So what this shows, what's stained green here in the upper left are individual T cells. And what's dark in the center of this sea of T cells is an individual muscle fiber. And they showed in other stains that the muscle fiber was a viable muscle fiber. This was not a dead muscle fiber that was being scavenged and cleaned up, but this was a viable muscle fiber that was being invaded by T cells. You can even see some green here into the middle of the fiber. In red, they've stained with a marker that shows cells that are activated. So these are turned on T cells. They've activated T cells. And over on the right on the top is a dual image, and what's yellow are activated T cells that are invading and damaging the muscle fiber. And this is really one of the key observations. This they showed in both inclusion body myositis and polymyositis. So the immune system is out there identifying and damaging muscle fibers. So what causes myositis? Cause we think of as what's the trigger, what are the mechanisms. The mechanisms are clearly immune, probably different in polymyositis and dermatomyositis. Shouldn't say probably, they are different. So what does myositis do to patients? Well, it depends. It depends on what the disease is, and it depends on the individual patient. So we see a spectrum of things. We see people with rapidly progressive, terrible myositis. We see people with very slowly progressive, more of an annoyance than a health issue. So there's a broad spectrum in how things affect individual patients. For most of these, because we think of myositis, muscle involvement is the hallmark, and muscle weakness is the primary symptom. But as I'm going to show you, many other things can occur in patients with myositis. So to think of muscle, how do we assess muscle weakness? Well, one of the things that I think is most important is at the top, you ask the patient how they're doing. Have you fallen since the last visit? How do you do with activities of daily living? So I typically ask patients a number of things: how they do with walking, how they do climbing stairs, are they having trouble getting up from a seated position, getting things to an overhead shelf, lifting a gallon of milk, sort of day and normal things. How are you doing with these? And then in the office, we'll test muscle strength manually. It's okay, it's somewhat crude. And then doing physiologic testing where you have a dynamometer, a tool that can measure in pounds or ergs or whatever, how much power there is. Other functional things can include, especially the cardiovascular folks use a 6-minute walk. How far can you walk in 6 minutes? This time stands is one that had been done. How long does it take to stand up and sit down 10 times from a standard height chair? And then the functional index, too, is one that was developed by Dr. Helene Alexanderson from Stockholm, who's here doing some talks also. We've done some work with her around that. There are other ways to look at muscle, though. One of them is to measure muscle enzymes. When muscle is damaged, enzymes that are normally in muscle leak into the blood, so we can measure blood levels of some of these enzymes. Honestly, and there are a number, CK or creatine kinase is the one that most people follow, aldolase is another, the LDH, AST, and ALT can come from other tissues but are in muscle and will tend to go up in parallel with the CK and aldolase. Honestly, I find people who don't see a lot of myositis, primary physicians, put more stock in this than the functional abilities of the patient or measuring muscle strength, because it's easy to do. You send the patient to the lab, they get the blood drawn, you get a number back. And then you've got a number that's quantitative as opposed to asking the patient who says, well, I'm weaker, I can't do as much. So, yes, you get a number, but I think a lot of us think that these are less important than the functional things in measuring how patients' muscle strength is actually doing. So we can use MRI to look for inflammation or scarring in muscle, and so with the MRI, so there are different sequences, you get different types of information from the MRI depending on how you program the machine. But with this type of sequence, muscle should be the darker tissue. So this is across the thighs bilaterally, and this is bone, so this is the front of the leg, this is the back, and white indicates inflammation. So there's a lot of inflammation here. The other point that I use this for is to make the point that where you take the biopsy, if you're doing a muscle biopsy, really matters. If you take the biopsy over here, you're likely to see inflammation. If you take it from here or back here, you may get normal muscle. So having a normal biopsy does not mean that somebody does not have myositis. Somebody can have myositis with a biopsy that was normal because it wasn't taken from an appropriate site. EMG is also used. Well, that's a good question. The question is, how do you know where to take it? And so there are three things. One would be to take it from a muscle that's demonstrated to be weak on physical examination. We'll use EMG to identify involved muscles, and we can use the MRI to identify involved muscles. So it's wanting to have an involved muscle, but not one that's been so involved that it's now damaged. So who's had an EMG? Fun? Yeah. Yeah. So my mother had my mother before she died came to Mayo. That doesn't make a good advertisement for Mayo, does it? Used to come to Mayo for her annual physical exams, and her 1 year, about 10 years ago, her internist wanted her to have an EMG, and so I walked her over there at noon and didn't see her again until dinner time back at home. And when I got there, she waved her finger at me. She said, "You didn't tell me about that test." So most people don't find them enjoyable, but you get information about the muscle. So at the top, this is what happens. They usually stick the needle in and record the activity as it's being inserted. Then they record activity when the needle is in the muscle and at rest. And normal resting muscle should be electrically quiet. That is shown here. There's really no activity. In patients with inflammatory myositis, we see this B through D group of things. The E is a totally different thing. So muscle in patients, muscle that's inflamed is electrically active. It's irritated. And then they will ask the patient to move the muscle, and you can record what happens to the electrical activity as the muscle is moving. And there are some characteristic patterns in people with muscle diseases as opposed to patients who have nerve problems that's causing muscle weakness. So we'll move on from the muscle side. This is what does myositis do to patients to other diseases. So in dermatomyositis, this is characterized by rash. And indeed, there are some patients with dermatomyositis who have no muscle involvement. So the rashes are key. These top two, the Heliotrope and Gottron's papules, are what's called pathognomonic. They don't occur with anything else. If you see these rashes, it really essentially makes the diagnosis of dermatomyositis. There are some other rashes, including the Shawl sign that I'll show you, and calcium deposition under the skin and in muscle called calcinosis that can occur with other disorders. So here is an image of the Heliotrope, this sort of reddish to lilac-colored rash over the upper lids. The Gottron's papules, where there is redness, raised lesions, and scaliness that can be somewhat shiny over the knuckles. If it doesn't have the scale and the shininess, it's called Gottron's sign. This isn't very prominent, I will admit. Here's the Shawl sign with rash that's in sun-exposed regions. And then involvement of blood vessels at the base of the nail, where we can see some prominence and dilatation of the little capillaries at the base of the nail, sometimes with hemorrhages or telangiectasias here. And this shows this calcinosis or calcium deposition that sometimes you can see visually, but shows up quite prominently. There's this fluffy white stuff on X-ray. And then there's what I already mentioned, amyopathic. So amyopathic, no muscle pathology. Dermatomyositis used to be called dermatomyositis siné without myositis. So these patients have cutaneous features of dermatomyositis but no muscle weakness. They might have elevated muscle enzymes but no weakness. Then the other concept is that a lot of other organs can be affected. This is probably mostly in polymyositis and dermato, so we worry a lot about interstitial lung disease, inflammation in the lung that can give way to scarring of the lung. There can be involvement of various areas along the GI tract with dysphagia, swallowing difficulty, loss of appetite, reflux because of esophageal problems. There can be heart inflammation. Inflammation can be in the muscle of the heart or in the lining around the heart. Fibrosis or scarring of the heart muscle, rhythm disturbances caused by inflammation. Finally, joints with arthritis, inflammation of the joints, so swelling and tenderness, or just pain, arthralgia, stiffness in joints in the mornings. Raynaud's phenomenon is overactivity of blood vessels clamping down, and with cold exposure, fingers turn white, blue, and sometimes red as they rewarm. And then fatigue, low-grade fever are all things that can come as the immune system seems to be activated. So I draw this a lot for patients. This gets to the concept of overlap connective tissue disease. So there's a host of autoimmune diseases. We don't see all of them. There are autoimmune thyroid diseases, autoimmune gut diseases. But of autoimmune, what we call connective tissue diseases, rheumatoid arthritis is probably most common, and lupus, this Sjogren's syndrome where the glands that make secretions are involved, scleroderma affects the skin, and polymyositis and dermatomyositis. And these can all overlap one with another. I can't draw the diagram so they each touch each other, but there can be features of all of these in patients with myositis. So we'll sometimes use this term overlap connective tissue disease, and to me that means there's enough that I could make a diagnosis of polymyositis, let's say, and I could make a diagnosis of lupus. That's overlap. Sometimes we see people with a hint that there's parts of something, but maybe not enough to formally call. And I tend to call that undifferentiated connective tissue disease, and we'll treat as an autoimmune disorder, but sort of wait for things to declare themselves before putting specific labels. And then there's something called mixed connective tissue disease that's a subset of lupus. But the terms all get confusing. Let me switch to IBM. So IBM was first described in 1967. And it was in a patient who had been termed to have chronic polymyositis, who wasn't getting better. And this researcher found particles in the muscle biopsy on electron microscopy that looked like viral particles. So he proposed this as a possible viral infection causing this chronic polymyositis. So it was first described in 1967. The term IBM was coined in 1971 to sort of because of the inclusions that are seen in the biopsies. We know that there are two forms, the sporadic form and the hereditary forms, and the sporadic and hereditary are similar with weakness that comes on slowly, CK that goes up some, but not to the extent that it can go up in patients with dermatomyositis or polymyositis. And there will be those muscle-like changes on the EMG, but some patients have nerve-type changes. The patients with the hereditary form tend to be younger and don't have inflammation in the biopsy, but look the same. So here are the clinical features of sporadic IBM. Again, Dr. Mayman talked about these, but just as a quick overview, that it comes on gradually. It's not an abrupt onset process. It takes years, not months, to get to a diagnosis. And some of that is that the symptoms come on so slowly it takes a while for people to seek care, and when they do, it can take time for the diagnosis to be confirmed. And sometimes that is because the inclusions accumulate over time, so there may be fewer of them earlier, making it harder to identify them in a biopsy. And with biopsy later, it can be easier to find, but it's often years to a diagnosis. The weakness can be generalized or localized to limbs that may be asymmetric as opposed to the polymyositis and dermatomyositis that are typically very symmetric in how the muscle weakness presents. Reflexes can become abnormal late. This dysphagia or swallowing difficulty becomes more frequent with later disease. There can be muscle pain, but it's uncommon, and more often I'll hear patients complaining of some achiness in the knees and around the thighs, and I think that some of that is because knee pain worsens if you don't have the muscle strength to help provide support and stability. And with the weakness, it's easier to pull some ligaments and have some other damage because you don't have the muscle support around the knees. And on the right, showing the typical involvement, finger flexors and wrist flexors are things, or weakness in those muscles are things that we don't see in polymyositis and dermatomyositis. There can be weakness affecting the quadriceps muscles, which is shown in the upper left. There's atrophy of muscle in that upper thigh, and that can lead to weakness of knee extension, and then weakness of ankle dorsiflexors, the one that make your ankles come up. Again, this is overview, so we're moving through things quickly. Anti-synthetase syndrome. So this was identified, it was known that patients with inflammatory myositis were at risk of developing lung inflammation called interstitial lung disease. And as people were identifying specific antibodies, autoantibodies, we're still getting there. This one called JO1 was identified, and it is highly associated with development of interstitial lung disease in patients with myositis. The other clinical features that show up with this syndrome are inflammatory arthritis, and indeed I've seen a number of patients who were diagnosed initially as having rheumatoid arthritis because the arthritis was what showed up first. And in time, they developed muscle weakness in the lung involvement. And so you can see there are published cases in the literature of patients with rheumatoid arthritis who were treated with a drug and then developed polymyositis. I don't think that's true. I think they actually had polymyositis all along. They got treated with a drug that wasn't enough to help, and then the other features showed up. But it complicates things. The other features are this Raynaud's phenomenon, mechanics hands, and low-grade fever. So here's an image of mechanic hands, this dry, cracked skin. This shows it over the fingertips. It can be on the palms. If I showed up in the job that I do with fingers like this, everybody would know it's abnormal, right? So it's seeing this sort of hands that look like they belong on somebody who works with their hands. So the last in the group is this immune-mediated necrotizing myopathy. So this is characterized by a biopsy that shows necrotic muscle fibers but no inflammation, and there are specific autoantibodies, the one towards signal recognition particle and this more recent one identified toward HMGCR. HMGCR is the enzyme that's targeted by statins, and indeed this is associated with statin use, and it's interesting that taking a drug for your cholesterol, some patients develop antibodies toward the target of the drug, and this gets linked to muscle damage. So very quickly about epidemiology, these are uncommon disorders. This older estimate, about 0.5 to 8 per million. Polymyositis, age-wise, polymyositis, dermatomyositis have two peaks. There's the childhood forms, and then there's a second peak in adulthood. Inclusion body myositis typically occurs in people over 50, and indeed in patients over the age of 50 with myositis. IBM, if you're asked to make a bet, what is it? Pick IBM because it's most likely over the age of 50. The sex distribution these are more common in females for polymyositis dermato. In IBM, it's just the opposite, that men are more frequently affected. This.
What age basis, like for the IBM
These are probably diagnosis, but hearing onset under age 30, it's described in people under 50, under 40, but it's less common. These are data from one of my colleagues in Rochester, where we have access to records that's pretty complete. So in this study, she found the incidence of IBM to be about 0.8 per 100,000, or about 8 per million, which is similar to what I just showed you on the last slide. Polymyositis was about half that, so about 4 per million. So that's new cases per year. This is the prevalence, how many people in the community have the disease. So this is about 7 per 100,000 for IBM, 3.5 for polymyositis. Our colleagues in dermatology did the same thing and came with an estimate of dermatomyositis of, this would be about 10 per million for for new cases, and this is this amyopathic, clinically amyopathic dermatomyositis, about 2 per million. And those are just some other studies show it. So what does myositis do? This was longish, probably too long. So it can do a lot of things depending on the disease, depending on the patient, and that leads into how is it diagnosed? Well, how is it diagnosed is that you go looking for the things that it can do to patients. So many of us think still about these criteria that were put together by Bohan and Peter. So these were the criteria they used to define cases that they included in their original study. And what's important is the title, that these are classification criteria. These are not diagnostic criteria, meaning these were not put together to make a diagnosis in an individual patient. These were put together to say that if I'm doing a study and I say I looked at 100 patients who met the criteria for dermatomyositis, most people would believe that 90-95% of them really had the disease. So it's meant for that type of use. But it's useful to guide our thinking for an individual patient. So if we have somebody who's weak or has muscle complaints, what are we going to do? We're going to look for weakness. We're going to look for the muscle enzymes. We're going to do an EMG. Think of doing a muscle biopsy. Look for the rashes. So these are the things that go into making the diagnosis. So again, the muscle biopsy is key. I showed you normal muscle. This would lead somebody to think that this is more polymyositis, more dermatomyositis. This one, the blue dots, aren't inflammation cells, but those are scavenger cells that are in sort of cleaning up debris from damage that's been done in this patient with necrotizing myopathy. So biopsy is very important to help make the diagnosis. In the biopsy, if seeing the vacuoles or inclusions, as shown here, this would lead to a diagnosis or lead toward a diagnosis of IBM. Again, another feature in the IBM biopsy is this Congo red staining that Dr. Mayman talked about yesterday also. So this is staining with a particular chemical stain that under birefringent light, the colors change from red up there to this yellowish down here. And this is one of the features showing amyloid in muscle biopsies of IBM. So there are some features on the muscle biopsy that are expected to make a diagnosis of IBM. More recently, we've been using these autoantibodies. So just background immunity. So antibodies are part of the normal immune system. It's what you make when you get your flu shot. When you get an influenza vaccination, you make antibodies toward influenza. And so the antibodies are in the immunoglobulin part of the proteins. And each antibody recognizes a unique protein called an antigen. So we've got thousands, tens of thousands of different antibodies looking for influenza, diphtheria, staph, strep. But there are autoantibodies. The same way as the concept of autoimmunity, we some people make antibodies directed toward things in their own body. And there are a host of autoantibodies. Some of them seem to cause disease. In other disorders, they're a marker. We don't know that they actually are causing disease, but it sort of indicates that there's some abnormality. And what I've shown on the right, that there are just a lot of defined antibodies in different conditions. So there are some with lupus, rheumatoid arthritis, this JO1 with polymyositis, some with vasculitis, thyroid disease, patients with celiac disease develop autoantibodies as well. There are some non-specific antibodies. I'll skip those. And so there, actually, in the interest of time, let me do this. There are, because this is a very nice synthesis or diagram of a number of different types of autoantibodies. So these are organized, and there are a lot of the anti-synthetase antibodies. So JO1 is the most common of these, but there are antibodies directed toward other synthetase enzymes. And if there are questions, we can talk about what the synthetase is. And these are associated with lung disease. There are some others that can be associated with lung disease, including this one called MDA5. There are some that are seen in overlap connective tissue disease with lupus and other patients who have myositis and lupus or other things. This SRP is associated with severe myopathy and swallowing difficulty. Both SRP and the HMG-CR antibodies are associated with this necrotizing myopathy. There has been one identified in inclusion body myositis, and not everybody with IBM gets it. It can show up in a few other autoimmune diseases, including Sjogren's syndrome, where there's inflammation of the glands making secretions. Then there are a number associated with skin disease, with dermatomyositis. This MDA5 is lung and skin. MI2 is the initial dermatomyositis. And the last couple are recently identified ones called NXP2, anti-NXP2, and anti-TIF1 gamma. And their significance is that they have an association with malignancy. And the risk of having a patient with myositis and malignancy goes up if either of those is positive. Doesn't mean that everybody's going to get it, and it's always a concern because once you know you're positive, you worry more. But it makes us think that those are patients who probably need more intensive screening, maybe more ongoing screening for cancers than other patients. But I've seen plenty of patients with those antibodies who haven't developed a malignancy yet. So, like I said, it causes more worry, but it also is a marker for increased risk. So how's it diagnosed? Well, a bunch of things. It's the good history, good physical examination, looking not only for muscle disorders, but involvement of other organs. It's thinking of doing tests, looking at muscle from blood tests, EMG, maybe a biopsy, looking for some of these autoantibodies. And nowadays, for new patients, we do these autoantibody panels in virtually everybody. So how's it treated? We're going to fill in the blanks. I didn't get all this developed right. But so this is what I'm going to show you is a general concept that I use for a lot of autoimmune diseases. And as I was revising this over the past week, I looked at it and said, well, now if we're going to think that there are that we're expanding myositis from just polymyositis, dermatomyositis, and IBM to now include this necrotizing myopathy stuff, I should really change this a bit. So this is sort of my treatment approach or thinking for patients with the inflammatory things that aren't IBM, so polymyositis, dermatomyositis, anti-synthetase syndrome, and patients who have overlap with other autoimmune disease. And for this, to my thinking, inflammation is central to what's going on. That's inflammation. The question is inflammation where? Because it's the inflammation that drives the symptoms. But what causes the inflammation? Well, for most of these, we think it is an autoimmune process that drives the inflammation. So what do you do to treat? I realize I didn't have a microphone. Can you all hear? It's pretty late to ask if you can hear me in the back. But nobody's raised their hand, so I assume so. So autoimmune process drives inflammation, causes symptoms. But in addition, the inflammation can cause damage. So I tell patients that, I want to treat you because we want to help with the current symptoms, but I'm also worried that the inflammation can cause damage. And I want to treat so we prevent future damage. So I think that the inflammation in muscle gives way to scarring and fibrosis, and some of that is reparable. I'm not sure as things flare that people get all the way back to where they'd been before they had the disease. And so I think there is some damage. We worry about that especially in patients with the inflammation in the lung, because the inflammation can give way to scarring, which is damage. Basically, damage is irreversible. I've got the scar from when I was a kid and throwing my pocket knife against the tree, and one of the times that bounced back at me and had to duck, and I've had the scar ever since, so I learned from that. But it is damage, so we want to prevent damage. So to treat, where am I going here? Steroids. Steroids are the key to quieting the inflammation. And upstream, though, it's the immune system pushing this, and so doing things to quiet the autoimmune process, I think, is important. You get some divergence from different physicians. How do you treat this? There are some who suggest that with dermatomyositis, polymyositis, you treat with steroids, and for patients who don't respond, you then add an immune-suppressing drug. I think many of us as rheumatologists are very comfortable using these drugs that suppress the immune system, because it's what we use for lupus and rheumatoid arthritis. And so I tend to use an immune-suppressing drug very quickly. And basically, I'll start the prednisone, start the immune-suppressing drug. And most patients get improvement if you give them enough prednisone, because it's quieting the inflammation. The issue is the side effects from the prednisone. So you can't leave people on high-dose prednisone forever. So you want, if you start prednisone at 60 milligrams a day, say, as a high dose, and the patient gets better, well, I've also started this immune-suppressing drug, and when you start bringing down the steroids, it really tests whether you're doing enough to suppress the immune system to then prevent the development of inflammation. So a lot of it, unfortunately, is trial and error. And it is to say, okay, we can get things quieted, now let's bring the prednisone down. And if things flare up again, you say, oops, guess we've got to do something different. So you go back up with the prednisone. If you don't change the immune-suppressing drug, same thing's going to happen when you taper the prednisone again. Most likely, these diseases do sort of sometimes wax and wane. There are times that they flare up and times that they quiet down. And maybe you can push the prednisone and just ride out a flare. But often, especially for newly diagnosed patients, when you first bring the steroid down, if things flare up, you probably have to do something more. So that might be pushing the dose of methotrexate or Cellcept higher. At some point it might mean adding a second drug. It might mean switching to a different drug. But it is sort of this trying to get things suppressed. So I really view it that what we want to do is to minimize risk. And where is the risk? There's risk in over-treating and getting side effects. There's risk in under-treating and leading to damage. So we want to treat enough but not too much. And then we want to get the combination of steroid and immune-suppressing drug to the point of minimizing the risks from the drugs. So it's trying to balance all of those risks. So that's sort of my general thinking to these inflammatory conditions. Now we get to this immune-mediated necrotizing myopathy. Well, the problem here is, I've told you that the immune system drives it. We can see these autoantibodies, but the biopsy doesn't show inflammation. But it seems that it's the immune system causing the muscle damage. And so what to do isn't totally clear. Most of the literature suggests that these patients do best when treated with steroids in high dose and immune-suppressing drugs, and indeed they probably need more aggressive immunosuppression than patients with general polymyositis and dermatomyositis. Well, then there are patients with the cancer-associated myositis. So the biopsy shows dermatomyositis, the skin rash is there, it's typical, looks like dermatomyositis, but oh, by the way, this woman was diagnosed with ovarian cancer as well at the same time. Now what do you do? Is the cancer related to the myositis? Well, in some cases it is. I've seen this patient with ovarian cancer, dermatomyositis, had the cancer treated, myositis went away. And yes, well, for as long as I followed her at least. So is it that the cancer was the trigger of the immune system, treat the cancer and the myositis gets better? That does occur. Sounds like a Nobel Prize. No. The question was which came first. Here it's not so clear. There are other patients where the cancer gets treated and the myositis is still there. So it's difficult to know. Most of the time we'll want to take care of the cancer. If the patient is, so the question is the cancer the stimulus for the immune system? Is the cancer driving the inflammation directly? And the question is, does the patient need something to treat the dermatomyositis as well? And typically, if the patient's sick enough, we might start them on steroids, get the cancer dealt with, whatever that means. Depends on the tumors, it's surgery, is it chemotherapy, whatever, and then see what happens to the disease. So I think the inclusion body myositis patient is in the same circumstance. The biopsy shows inflammation. This is an autoimmune process, but there are these inclusions. And I think that the question is, do the inclusions drive the immune system? Do the inclusions cause inflammation directly? Or do the inclusions cause damage to the muscle? So we know that patients who are treated tend to have progression of weakness, even though the weakness may be the rate of worsening of weakness may slow down. The CK and muscle enzymes may come down, but there is debate about whether to treat. And some of the question is, even if we quiet the immune system, which seems to be activated, shown in those activated T cells, and we can get rid of some of the inflammation, it may be that in the long run the inclusions are causing damage to the muscle, and if we don't have anything to treat the inclusions, get rid of the inclusions, then the damage may progress. So it may be a twofold thing, and that's what Dr. Mayman was talking about whether there can be drugs that work in an IBM because they're working on that unfolded protein concept. So as far as using steroids, I'm going a little long because I'm down to the end, but it's almost 8. So I tend to start, when I'm going to use prednisone, at high doses, typically 1 milligram per kilogram per day. We usually stop at 60 milligrams. If patients are severely ill, we might use intravenous doses. If you split a dose of prednisone up, so instead of taking 60 all at once in the morning, you take 20 3 times a day, that's got more bang to it. It's also got more side effect risk. So I usually go for about a month and then slowly taper. I use an immune-suppressing drug early, and then it's to pay attention to side effects. Think of osteoporosis and infection. Then it's how to taper. Everybody who uses prednisone has their own tapering schedule. Everybody thinks that theirs is the right one, but this is what I tend to do. And then what immune-suppressing drugs. So this wasn't a talk about treatment. This is an overview about myositis. And the overview is there are no studies to say any particular drug is the best immune-suppressing drug to use for these diseases. The data, there aren't big enough studies to be able to say this is the preferred drug. So I usually think of the upper left as first-line agents, methotrexate, azathioprine, mycophenolate, as the first immunosuppressive drugs that I would consider. For individual patients, there might be reason to avoid one. If it's a young woman who wants to get pregnant, methotrexate and mycophenolate are not good choices. Azathiopриne's okay. If it's a patient who has interstitial lung disease, well, methotrexate sometimes can cause some lung trouble. So our lung doctors would prefer that we not use it for them because it just complicates things. So the choice is individualized, but there's probably no data that one's better than the other. For patients who don't respond to one, I usually go to a second one, and at some point we'll think about some other treatment. IVIG is very good for skin disease, for dermatomyositis. It often gets used for patients with severe swallowing difficulty. Rituximab is widely used, and there are other immunosuppressive drugs. For patients with severe disease, cyclophosphamide is a very potent but very risky immune-suppressing drug. But it's something that we'll use for patients who are in the ICU with severe lung involvement, for instance. There are studies ongoing with some other immune-suppressing drugs. Acthar has been promoted. I've honestly never used it. I think that there aren't data to support it. Then there are the other things. Pneumocystis pneumonia is a particular lung infection that's a risk in patients on high-dose prednisone. So we'll use trimethoprim sulfamethoxazole Bactrim as a prophylactic drug. It's important to get, say, up to date with immunizations, thinking of osteoporosis, bone density, calcium, vitamin D. I've not given much discussion to involvement of other allied health professionals needing physical therapists, occupational therapists, attention to mobility, assistive devices in individual patients, fall prevention, working with swallowing difficulty, and finally exercise. When I first got into this field 3 decades ago, the mantra was that patients with myositis should not exercise. You're going to damage the muscle more, don't exercise. That was wrong. It's simply wrong. And Dr. Alexanderson, who I mentioned earlier, has been a proponent and has done studies showing the value of exercise. With patients who have severe active inflammation, we don't need to go out and try to pump iron, but it is saying active is important and gradually increasing exercise. So how's it treated? General overview is steroids quiet inflammation, an immune-suppressing drug to quiet the drive of the inflammation. And that was what I told you, and I will take questions. It is 8:02. I'm not sure when we need to be out.
Yours is one of the presentations that is on the website, so you can have
the image.
Comments,
right. Yep.
If you go to the home page, it's between the patient stories and the spine support group. There's a small bar that says presentations or whatever, and so you can click there. And it's not, a lot of them are not online, but yours is one that is. We appreciate that, but I wanted to make sure people knew that because they may not have checked. So.
Thank you. It got there at 3 o'clock yesterday before my 4 o'clock talk. So, I'm sorry. I saw this hand first, so then come back.
So he has antisynthetase, but his muscle biopsy came back with dermatomyositis, but he has no rash.
Yeah.
Is that something that we kind of look out for?
So the question was anti-synthetase syndrome. Biopsy shows dermatomyositis, but no rashes there. So honestly, I don't worry about that, about what the myositis is, whether it's dermato or polymyositis. So clinically it looks like polymyositis. The biopsy is called dermatomyositis. And that really gets to, the biopsy was called that because of where the inflammation was. I don't know that the label of it, what type of myositis matters. What probably matters most is what's happening with the strength, what's happening with the muscle, and what's happening with the lung, because those are basically the targets for this individual, and that's what we want to treat. And I don't worry whether it's right. It's an inflammatory myositis. It's got the antibodies and it's got the clinical features, and sometimes it is the question of part of part of the disease has gotten better, another part's gotten worse or hasn't changed. And what do you do with treatment? So we'll sometimes see patients where the skin gets better, but the lung on the breathing tests is worsening. Well, you've got to pay attention to that. And so it's, what is it that gets your attention and needs to be treated?
My question is, you talk about different types of myositis. Of course, mine is the IBM. So when you talked about the steroid, there was a question mark behind the steroid IBM.
Yep.
and so that's not necessarily helpful. The steroids aren't necessarily helpful for IBM. Is that correct?
I thought you meant the question mark wasn't helpful. So the question was for IBM, my slide about treatment had a question mark after steroids. So there is debate about what to do with IBM. And if you talk to neurologists, they historically have said you don't treat it because it doesn't get better, and you expose the patient to risks of the treatment that if it's not going to help, why take those risks? On the other hand, there is inflammation in the biopsy, and it's got the immune system driving it. And so I tend to treat. Neurologists often tend not to treat, although some of them will, especially if there's inflammation in the biopsy or more inflammation. So it's not clear, because I think in the long run, so my view is that with treatment, steroids, an immune-suppressing drug, the CK, the muscle enzymes can come down, but in the long run, it may be the accumulation of those inclusions that really causes the long-term weakness and lack of response. But it seems that if you can maybe slow it, if you can get rid of the inflammation, maybe you can slow it down. So my personal approach is that with patients with IBM, first, I often get them to see one of our muscle specialists in neurology just to make sure they get a balanced view of things. And I will treat, but I don't treat as aggressively as I would somebody who has clear polymyositis or dermatomyositis. With those patients, I think it's worth taking the risk of going to a higher dose of prednisone. So with patients with IBM, I might not give more than 30 or 40 milligrams of prednisone as opposed to 60 to 80. If I'm using methotrexate, I maybe don't push to as high a dose as I would with the polymyositis.
Question mark.
The question mark stays. The question mark was very intentional because there isn't evidence. We just don't know. Yeah.
Obvious physical challenges, and you go through the diagnosis for IBM, like the vascular slide that you showed. Biopsy says not really there. Your blood test say negative. But you see all the other symptoms. I know it takes 6 years on average to diagnose, which is like, all right, what's the point of doing everything you're doing? But if something says it's not IBM, then what are the tests that you do, or how can you find out what it is?
Yeah. I don't know.
I feel like there's a lot of people that are confused, especially professors and doctors, about diagnosis when results show it's something negative.
Yeah. So I don't know if everybody heard that. The question is, what happens when somebody's ill, but having problems, there's weakness, but the biopsy, the workup doesn't confirm the diagnosis, essentially. And it is a difficult thing. So the question is, are you willing to treat, or assuming that you're going to treat anyhow, how it's dealing with uncertainty, honestly, to say, do we know what this is? And if we don't know, at what point do we do things to try to make the patient better, even if we don't know what the diagnosis is? So honestly, the neurologists have long, I think Dr. Mayman showed this yesterday, the original criteria for IBM were strongly driven by the biopsy. And you really needed to see the biopsy changes. And so if you didn't have all of the right features in the biopsy, and our muscle pathologist is like this, he'll say that things are suggestive of IBM, but there is missing that last feature in the biopsy that it can say this is it. So they've got that sort of level of certainty. If you've got all the things in the biopsy, then it meets the criteria. If you don't, well, this could be IBM, but he's not going to make the diagnosis on the biopsy. So lately, what I've seen over the past few years is the neurologist saying, well, in addition to the biopsy, yes, the biopsy is important, but in addition, we recognize sort of the pattern of weakness, that when it's affecting the finger flexors, the wrist flexors, and the quadriceps so prominently, that's now getting more importance from them. There was a new set of criteria that I didn't allude to here. Dr. Mayman talked about yesterday. I had the privilege of working with the development of this, but it weighs various factors to suggest a diagnosis. Again, these are classification criteria, not diagnostic criteria. So they're meant for studies. So it's all sort of statistics. But it includes some of the clinical features to say, yeah, and I'm pretty sure that the tool says that we would call this IBM with 90% confidence or 60% confidence, something like that. But it gets to dealing with uncertainty, and if you're uncertain but think that this is right, how do you proceed from there? But
doing the reoccurring biopsy on muscle to see how it changes, year to year. Is essentially right here. You're saying one way to go.
So
Like is the blood test more definitive?
I don't think the blood test is more. So you're asking specificity. Does it occur in other things? So the blood antibody in IBM is can be seen in other disorders. So it's not that it's only in that disease. But again, I'd argue that, gosh, if it's positive and the pattern of weakness is correct, that's another piece of evidence to sort of make me more confident in the diagnosis.
Can I just pop in a comment?
Mm-hmm.
I had a muscle biopsy done by my dermatologist in Atlanta, and it was red at the University Hospital, and they said that I had polymyositis. I went for a second treatment because I suspected that I had IBM, not polymyositis, and they asked for copies of the slides, and the slides were sent to Johns Hopkins, to myositis, and they were read at Johns Hopkins. They said it was definitely IBM, they saw vacuoles. Whereas the people who read the slides the first time at the first university hospital did not say vacuoles. So I'm wondering with also the interpretation.
Oh, so some is the experience of the people reading the biopsy. So we have.
Second opinions are always.
So second opinion is an option, and honestly, whenever I see a patient with myositis who's had a biopsy done elsewhere, I always ask to get the slides sent for our pathologist to read them, because we have muscle pathologists. Muscle's the only thing they do, as opposed to in the other places where they might be doing other things. So there is experience counts for something, but also repeating the biopsy. I think that the natural history of IBM is that the number of inclusions increase over time. And so second biopsies increase, just because it's a couple years later, 4 years later, increases the likelihood of finding them, because they're
You're getting the biopsy from the part.
right. So it's picking the right muscle, and sometimes I think that people come to a place like Mayo or Hopkins a few years later and they get the biopsy and think that we're geniuses, and it might be simply that it was more time and it was much easier to find the inclusions. So, more questions? I'm not sure when the room's needed next.
Hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too you can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.